This is the EDology podcast. I am your host, Elka Kubaku, licensed social worker and psychotherapist. In this podcast, we explore divisive issues around food, health, and body image with the goal of mending relationships within the eating disorder recovery professional community and creating a space where a multiplicity of perspectives can coexist harmoniously. This podcast is uncensored and encompasses the political and ideological spectrum. If you believe something you hear is harmful or misinformed, please be respectful to the speaker. And also, feel free to reach out about recording another episode on the same topic from your vantage point. My hope is that if, as professionals, we can hold each other's stories with respect and compassion, we'll be better able to do so for our clients. Eating disorders can be deadly. They have one of the highest mortality rates among mental illnesses, both as a direct result of medical complications and because of the increased risk of suicide. Because of this, clients with severe symptoms often require continuous support and medical monitoring that can only be provided in higher levels of care. Active suicidality and severe malnutrition can warrant hospitalization, sometimes involuntary hospitalization. But what happens when patients have experienced treatment trauma in higher levels of care? This question is especially painful in light of stories of abuse emerging from some of the larger treatment facilities. How do we support someone who has been traumatized by the very treatment they are now being recommended? How do we help a client who refuses higher levels of care despite engaging in life-threatening behaviors? And how do we balance the need for treatment without pushing someone into a place that has deeply hurt them before? In this episode, Sandy James shares her experience cycling through hospital stays and higher levels of care, being subjected to a tough love approach while struggling with opioid misuse and disordered eating, and ultimately finding recovery through purpose and harm reduction rather than abstinence and containment. Sandy discusses how she now works with high-risk clients in outpatient settings. She explores how to navigate suicidality while creating an environment where clients can share their deepest, most painful experiences without fear of hospitalization as an immediate repercussion. This episode contains some heavy topics that can elicit strong feelings for anyone who has lived with or supported someone through an eating disorder. Please take care of yourself, and as always, feel free to reach out with any reactions. Sandy is a registered psychologist with over 20 years of experience in mental health, eating disorder treatment, substance abuse recovery, and trauma care. She takes a harm reduction, client-centered, inclusive approach to healing. Her primary focus is trauma recovery, especially in individuals with co-occurring substance use, food-related challenges, or compulsive exercise behaviors. She integrates evidence-based therapies with family coaching and somatic and experiential therapies where appropriate. She is also a certified eating disorder recovery coach through the Caroline Costin Institute and provides real-time support for recovery challenges. Sandy is currently pursuing a PhD on the intersection of eating disorders, substance use, and trauma. She brings both professional expertise and lived experience to her work, offering compassionate, informed guidance through recovery. Hi, Sandy. Thanks for joining me today.
Hi, welcome. Thank you. Not welcome. I'm joining you. It's 5 a.m. There might be some blips in my brain.
Totally. So, can you start by just telling me a little bit about what you do professionally in the food, body image, eating disorder recovery world?
Yeah. So I'm a psychologist and have lived experience of multiple co-occurring diagnoses, which places me in I think, somewhat unique position in the field. So I work in private practice at the moment. I have worked at in psychiatric inpatients. I have worked in eating disorder inpatient, eating disorder residential, drug and alcohol residential, and now I'm in private practice in Australia and completing my PhD researching treatment trauma, really, in a nutshell. So that's fun.
Treatment trauma, does that have personal relevance to you, or what drew you to that?
It does have relevance to me historically, like being harmed by um, mandated treatments and those kind of events that have happened.
Yeah.
Also things like back in the day, they had that tough love
Hmm.
philosophy, and like, man, that did some massive damage to my relationships with my family, and
Hmm.
some of those have been repaired now. But
Well,
yeah, so and then constantly hearing, like, working in the field and seeing people be harmed by treatment and recognizing for myself that this is ongoing, right? Like,
hmm.
this is just not something that happened in the 90s, 2000s, like when I was in treatment. This is still happening now. And
Yeah.
how do we make that less harmful
Hmm.
for people?
Yeah. Tough love. Are you talking about the sort of like let them hit bottom and then look at help kind of approach, or what was that like?
Yeah, like if they don't get help, then you can't talk to them. Don't let them into your house.
Wow.
All those kind of things. So like essentially just I got cut off
Hmm.
um, for a period of time at
Wow.
the recommendation of professionals. So like when you're in early recovery, and like I was not doing great, like I bounced in and out a lot, and that definitely did not help.
What a way to be told to treat somebody you care about who's in so much pain.
Hmm. Yeah, I have had conversations with some of my family about the impact of that on them as well. So the research that I'm doing is looking at the harm that's happening not only for the individual person who's seeking treatment, but also for their family and the clinicians involved in their care.
Yeah.
So it's a
Hmm.
three-pronged kind of
Hmm.
uh, analysis, I guess, of what's happening in the world of eating disorder treatment and how it's impacting everyone, and then thinking about how can we reduce that when
Yeah.
it's happening. Yeah.
I want to go deeper into that, into some of your story and some of the harm that you're looking at caused by residential treatment. Before we do that, can you tell me a little bit about harm reduction and what that means in the world of substance abuse and also in the world of eating disorders and wherever those two overlap?
Yeah, I think there's a big overlap a lot of the time for various reasons, right? Like they both provide an escape from whatever is going on. But
Yeah.
harm reduction is just, it's like abstinence or full recovery, for want of a better description, is at one end of the harm reduction model. So it doesn't include the abstinence model, like that is part of it. And I think that's a misinterpretation in a lot of clinicians and people, that if we're doing harm reduction, we're not working towards abstinence. And that may be the goal, and it may not be, but it's about how can we keep you safe while we build your skills to build a life worth living. And
Mhm.
if you can have a life worth living without distress and like massive impacts on your life and still use substances, for example, then go
Mhm.
for it. Right? Like, how can we manage that so that A, you're not going to die, you're not going to
Mhm.
lose your job, you're not going to end up in prison, like whatever. And I
Mhm.
think the translation of that into eating disorders is meeting the client where they're at. So
Mhm.
if the meal plan is not being met 100%, how can we work towards that in small steps? And how can we reduce the impact of the eating disorder on your day-to-day functioning? And that will generally include eating more. But
Mhm.
the way I work is that with very strong collaboration and consultation with the client. What do you think you can do this week, and how can I support you? And then next week we go, okay, how'd it go? Was it too big a step? Not big enough? Like, what's going on with that? And just navigating through to get
Yeah.
people to a point where they are happy-ish,
Mhm.
as happy as you can be
Happy-ish.
in the current climate.
Yes. So when you say abstinence is not excluded from harm reduction, it can be something to work towards. And if somebody's not there yet, you're willing to meet them at a place somewhere before
Yeah.
abstinence, or maybe if somebody doesn't plan to or want to get there, there's the option of meeting them at some place before that, where they might still be using, in the case of substance abuse, substances or eating disorder behaviors, but in ways that are not dangerous or destructive,
Yeah, or less dangerous.
less dangerous.
So if you think about like, uh, we go with purging, right? Like purging is harmful for the body.
Yeah.
And if you're not at a place where you can cease that behavior, then how can we reduce it or make it so that your teeth don't fall out, for example, or
Mm-hmm.
whatever? Like, um, reducing the amount of harm from the behaviors if we're not in a place where the behaviors are going to stop. Because what that also promotes is like honesty in the therapeutic relationship. Like, I don't
Yeah.
want people coming in telling me bullshit, right? Like,
Mm-hmm.
it's a
Yeah,
waste of their time and it's a waste of my time. And I'd rather know,
for
yes,
sure.
I did this behavior 16
Mhm.
times this week and I want to reduce it to 12, right?
Yeah.
Then how can we do that?
And part of encouraging that honesty is decreasing the risk of repercussions. Like you will be sent to
Yep.
residential if you tell me you've done this, which I've definitely seen in working in higher levels of care where I've had clients hide things from me and even having a strong therapeutic relationship where they're like, I was about to be discharged. I don't want to extend my stay here right now.
Yeah.
The
And I
other,
think the approach with that is like just saying to people, like, because I work with high risk clients, right? So
yeah,
sometimes I have clients where from one week to the next, I'm not sure if they're going to
mhm,
make it, right?
mhm,
But that treatment trauma piece for some particular people that I'm thinking of means that they are unwilling to go to hospital because that makes everything worse for them. So how
yeah,
can we navigate that? And that comes with a high risk, right? Like eating
mhm,
disorders are deadly
yeah,
and people are going to die. And that is something that I will talk openly about as well.
yeah.
And um yeah, that's a
Mhm.
completely different podcast, I think.
It is, and also it feels like the major or main hesitation that I would have that people would have when talking about a harm reduction approach of just I will meet you wherever you're at and we'll work on that together is how dangerous it can be. So I am interested in hearing how you navigate that knowledge that this person, we don't know if they'll make it, and returning to treatment for them just doesn't feel like an option right now. And I'm willing to hold space for that. Tell me what that looks like or what that means and how you navigate that.
I don't know how I navigate
Mhm.
that. I just do. Like,
Yeah,
um, I will encourage people and I'll work with them to try and find a facility that might feel comfortable for them, right? So I'm not like
mhm.
going, yeah, we're just going to let you like
Right.
kick the bucket and that's it.
Mhm.
It's like,
Yeah,
what, how can we work together with them in the driver's seat, right? And I know that we may not be driving in the direction that is what everyone thinks we should be.
yeah,
And that sense of control that people have can actually help them enter treatment. So I
yeah.
have someone recently entered a hospital-based treatment for nutritional rehab.
Mhm.
That took months to get to
Yeah.
that point, and we got there, right? And that means that the harm is going to be reduced because they were actively engaged in that choice making.
That they don't have the helplessness of being forced into somewhere.
Yeah, and the fight like that, like I know for myself, like when I was mandated treatment for
Yeah,
whatever I was mandated
for
for,
sure.
like multiple things at different times, um,
Mhm.
the fight was huge. Like that was prominent.
Yep.
I was fighting against everything. And
Mhm.
when I chose treatment, it
Mm-hmm.
was coerced. Yes, it was coerced.
Yeah.
Like, I don't know that many people actually enter treatment fully voluntarily. Um,
Mm-hmm.
but at the end of the day, it was my choice and I was voluntary. And if I didn't want to be
Mm-hmm.
there, I could exit myself. Right.
Yeah.
And I worked with my clinician to build a safety net around that. So I couldn't just impulsively discharge. Like, I had to have conversations with them about what I was thinking. And then generally I would end up staying. But
Yeah.
yeah.
It feels like as I'm talking to you, there are two very heavy realities that you're holding side by side that many people can only really tolerate holding one at a time, and the other gets discarded. And those two are the lethality of an eating disorder, how it can kill someone, and the danger of that, and also the treatment trauma and the helplessness and coercion that comes along with that.
Yeah.
And you're really holding the like both of those in a very deep way and finding a way to navigate that, which is of course complicated.
Yeah. I wish I could succinctly describe, because people ask me that question about, like, how do you navigate not knowing if your client is going to turn up next week because they may be dead? And
Mm-hmm.
like, the honest answer is I actually have no idea. Like,
Mm-hmm.
I don't know how I hold that space, and I
Mm-hmm.
suspect that there's a level of dissociation from the
Yeah.
reality of that to
Mm-hmm.
protect my own well-being, and
Yeah.
also being able to accept that in myself. Like, I have to compartmentalize, because if I spend my whole time worrying about this one client, then all the other ones get missed out.
Mm-hmm.
So I
Yeah.
have to work out like a way to maintain my focus when I'm there, but not carry it over into other sessions with other clients and let my fear
Mm-hmm.
interfere with their treatment.
Yeah.
I wish I knew how I did that. One day I might figure it out, but yeah.
There's no easy answer. The phrase that's coming to my mind now is that from Viktor Frankl that someone who has a why can navigate almost any how, which leads me to the question, what has given you such a deep appreciation for both of these? And can you share some of your own experience, both of the danger of an eating disorder and also of the harm that can be caused by treatment when it's forced?
Yeah, well, man, I've been involuntarily admitted to treatment at least 5 times. I had, like, reality, I have no idea how many times that was. Like, I was in and out of hospital frequently for various things, but um, one treatment episode that I remember really vividly is being put in an adult psychiatric ward, and there were 6 beds for eating disorder kids like me. Like, I think I was 19, maybe. Um, or some maybe a bit older, be a little bit time blind, but uh, there was us and there was them. And I remember really vividly sitting at one end of the hallway and watching a lady walk down the hall in one direction, taking off her clothing, one item at a time, and then doing a U-turn and coming back and putting them back on. Right.
Mm-hmm.
And she did that for hours. And I remember sitting there going, like, this is my life. Like, that overwhelming sense of hopelessness and helplessness, and like that feeling of being a disregarded member of society, like you almost don't exist anymore.
Mm-hmm.
And that doesn't sound traumatic, but at the time for me it was
Yeah.
like, it was like my life ended. And then on top of that, like the feeding thing, like, if you don't eat this, then you have to have this other thing. And um hospital food in the 1990s was indescribably
Um,
unpalatable. Like, hospital food now is pretty crap anyway, but
mhm.
like, back then it was like just mush. So yeah. those kind of things, and how to navigate being strapped into a bed for
Oh my God.
hours or put into a padded room or having so like I have had tube feeding only one time, managed to avoid that, but I've seen like a lot of difficult emotions come out of that. Like the recognition of the need for that stuff is there, but
Hmm.
how it's initiated, I think, is the aspect that we need to look at. Not
Hmm.
that like we don't never mandate someone for treatment, right? Like
Hmm.
ethically to protect our certification, sometimes we have to, but um, how do we do that in a way that's most helpful for the client, and how do we navigate any rupture that happens as a result?
Yeah. It feels so tricky also because hospitals are often not really healing spaces. Like you described that feeling, those big,
That was such a politically correct way of saying that. Often not healing spaces.
you mean gross understatement? Uh,
Yeah. Yeah.
yeah,
Well done, though. Very nice. Very nice.
yeah, a much softer way of describing something that was very, very horrific when you
Yeah.
experience. Yeah.
Yeah. And on that, from the outside looking in, like with my research, I've had people go like, what is that actually trauma? And I'm like, you don't get to decide that,
Hmm.
right? Like, because trauma is not the event that happens. Trauma is the response afterwards, really,
Yeah.
or the lack of response afterwards. So something like two people can have a near-death experience. One
Hmm.
develops PTSD or whatever, and the other doesn't. And what are those factors? Like, what's the difference between the two? And generally, I think the research, even though I said I don't remember research, I don't remember who said it, but
Hmm.
the research suggests that it's not necessarily the event itself, it's about the support or lack of support that we get afterwards that
Hmm.
generates the trauma. So being left, for me, being left sitting in a corner at the end of a hallway watching this woman was traumatic, right?
Yeah.
For hours. I was left there for hours. I was like curled up in a fetal position, just
Oh my God.
100% focused on this woman. And no one noticed. And that was the impact, I think, was not the fact that I was watching this woman, because now I think about it, it was
Hmm.
almost like entertaining, it kept me
Yeah.
occupied for hours. But
Hmm.
the fact that no one noticed I was there, no one came to see if I was okay, like
Hmm.
all of that stuff.
Yeah. The isolation, just being locked away
Yeah,
and forgotten.
no one can see me. Like, what the
Mhm.
hell, that kind of thing. I don't actually
Yeah.
exist, blah, blah, blah.
Hmm.
Yeah. And
When you,
then I think also the harm reduction thing, like if we go back to that harm reduction, um, where my passion for that comes from is uh,
Mhm.
primarily from substance use treatment. So going into treatment centers that were, or detoxes or whatever, but
Yeah.
12 steps. Like you have to be abstinent. You have to go to meetings every day. You have to
Yeah.
do this. You have to do that. And if you use again, then it's your fault because you're not doing the program
Mhm.
properly. Right. And that messed with me big time, to the point that abstinence became like completely off the table for me at the time. Like I was just not interested. I'm like, you guys can all go and get fucked. Like I'm going to be okay and you can't tell me what to do, kind of thing. And
Mhm.
um, yeah,
Tell me,
that
tell me what you mean when you say it messed with me big time. What were the after effects or the effects at the time for you of having this model of either I'm entirely abstinent or it's my fault and I've fallen back completely?
yeah. So an example that readily comes to mind is like I was in treatment for a heroin use disorder, right? So I used heroin for a long time, and that alternated generally with the eating disorder. So it was like one or the other, sometimes both, but
Yeah.
not so much. But um, going into treatment to try and stop using a particular substance, but not like still wanting to have a glass of wine. with dinner, for example,
Yeah.
when I had dinner, but like I'll have a glass of wine, and if I had a glass of wine, then that would be a relapse. So my
Hmm.
brain would go, okay, if I've got to start my
Hmm.
counting again, then I'm going to make sure it's worthwhile. And then I would end
Yep.
up using and back in that loop. So it
Hmm.
kept me in that relapse spiral for a really long time. And then the labeling of being like, she's a chronic relapser, she's dangerous, don't talk to her, blah, blah, blah.
But that was the messages that you were getting from the recovery community.
Yeah, yeah. I was called a chronic relapser, like that was a title that I earned, I guess.
What a, oh my God, my cat is just like climbing up to me, but what a label to have attached to you.
Yeah. And I wore it with pride, like, which
Mm.
caused a lot of harm to me, but it was a label that I could identify with, like I'm the rebel,
Mhm.
like I'm not going to follow your rules, I'm going to do it my way. And like that eventually worked out really well. But
Mhm.
I think if there'd been a gentler approach back then, the outcomes would have looked a lot different for me.
Yeah. So it had the effect of putting you in this mindset of like either I'm completely abstinent or if I'm drinking a glass of wine, I may as well make this worth it and have everything. And it also put
Yeah.
you very much at odds with your treatment team and with anybody who might have been a support in your
Yeah.
recovery.
Yeah, and that's where that tough love thing came in, right? It's like, well, if she can't stay abstinent, then she's using, and you don't want to talk to her because that's not safe. And with the eating disorder, it was also like, um, like if you don't follow the plan, then
Mhm.
you're doing the wrong thing. There was no exploration of like what's what are the blockages that are stopping you from being able to
Mhm.
do what you say you want to do, right?
Yeah.
Like I wanted to be well and I couldn't, and no one explored that space in between.
Yeah.
So yeah.
I'm going to ask you a little bit more specific questions about your treatment trauma. If anything doesn't feel comfortable to answer, feel free to tell me. But
Oh,
you
I
had,
will.
okay, good. So you had mentioned before being held down, put into padded rooms. Can you tell me a little bit more about that? As somebody listening who hasn't been in that environment, just to give me an appreciation for what you've been through and who's ever listening, like what is actually happening on the inside.
Like just being those soft. This was an admission for self-harm, which also is a fairly frequent co-occurring
Yeah.
symptom, right? So, but I self-harmed in hospital, which is
Hmm.
such a good plan, right? But I actually don't remember, and so that's a whole. I didn't know I'd self-harmed, and then the next thing I was tied to the bed with
Oh my gosh.
like things around my wrist and things around my ankles
Hmm.
and sedated. Like I don't know what I
Wow.
was given, but I was stoned, which I was happy about, but I didn't like not being able to move and stuff like that. And then
Wow.
so like yeah, a lot of screaming and just that
Hmm.
frantic, like I'm gonna die here. I'm stuck.
Wow. So you were literally
And
tied down to a bed.
yeah, yeah. And that still happens. Like it
Mhm.
literally still happens. People still
Yeah.
experience that. And the padded room thing, it wasn't a whole padded room, like three walls were padded and it was glass walls. So it was like a fishbowl, mattress on the floor, nothing. I had pajamas with no strings. I couldn't even have socks because I don't
Mhm.
know why. Um, and just people looking at you constantly through a glass, it was like being in a fishbowl.
Wow.
So
And no other human in actual contact with you beyond looking in at you.
yeah, they'd bring meals.
Hmm.
Sometimes I would throw it at them. Like I was not an ideal patient by
Oh,
any stretch of the imagination, but
Of course
Yeah.
you weren't. You were locked in solitary confinement. Like, which of us would be sane in that circumstance?
Yeah, and it was like, like you sit on the inside of that room on the floor. It's cold, it's dark, it's dismal. Like it's not dark, it's actually really bright, but it felt
Yeah.
dark. And if I wanted to go out for a cigarette, then I would have to knock on the window and get someone to open the door and take me out.
Mhm.
And but I wasn't allowed to have any of those. Like I had no possessions
Yeah.
with me. And it was just like watching the world from inside a bubble.
Hmm.
Yeah.
Wow. You're being deprived of everything that allows a human to function, of human contact, of a sense of meaning, purpose, and autonomy. And
Yeah.
when you react to that, you're being punished for it.
Yeah. Yeah.
Wow.
And if you be good, then you can come out into the ward with the milieu. But only
Hmm.
if you're good. Like you can't swear, you have to eat all your food, you have to like whatever. There were rules.
Yeah. It's,
And as a 20 plus year old, like I was like 30, I think I was early 30s at that point. I had so much trouble making sense of
yeah.
where I was, why I was there, who I was. Like
Hmm.
there was no capacity to think about a future because it was about surviving
Hmm.
in the moment. Yeah. So
Yeah.
the psychologists or whatever would come in and then you go, like, they're like, okay, so what do you want to do when you get out? And I'm like,
Hmm.
what do you mean?
Like there's a life outside here, there's a moment beyond just surviving.
Yeah. And like I have a choice. Like
Hmm.
I don't know how to make I don't know what choices to make anymore because it felt like every choice I made got me in more trouble. So
Wow.
yeah, not making choices became a go-to. So just kind of flowing.
Mhm. Wow. What got you out?
Mountain bike riding,
Tell me
weirdly.
more.
I moved, I was living in Sydney and that was really not a good environment for me as
Mhm.
I couldn't get clean. I was on methadone. I'd finished uni, which was a miracle, and I got a job in a small town in the middle of fuck ass nowhere, Australia, and went there and things escalated for a bit. And
Mhm.
that's where some of those admissions were. And then I found a doctor that was willing to work with me, not against me. So that made a massive difference. Like we used a medication that prevented opiates having any effect. So that took that one out of the picture for a period of time.
Yeah.
And the mountain bike riding, I can't even tell you how I got involved in that, but someone must have said, like, come riding. I'm like, okay, fine. Because I've always been an athlete as a younger person as well. So I went mountain bike riding. And then to be able to compete in mountain bike riding, I had to eat. So that then kind of sorted that out to some degree as well. And I managed to be able to function. And then
Mhm.
as time went on, I kind of did the deeper work and still am.
Mhm. Yeah.
Yeah.
So the turning points for you were finding a doctor or provider who was willing to look at not just the fact that you're relapsing, but what's getting in the way and work with
Yeah.
you on that. It sounds like in this case, medically. And alongside that, you tapped into your purpose or just something that felt something that you loved. And
Yeah. That was a little bit dangerous. Like it gave me adrenaline, it gave me joy, it taught me mindfulness, like how to be here now. And
mhm,
that is, I think, the primary lesson that I got from it, besides that
yeah.
life doesn't have to be serious. Like you can go out there and have fun
Mhm.
and do things that are a little bit risky
Yeah.
without, hopefully, without doing too much damage.
Hmm.
Like I have broken bones and stuff, but that was from running because I have trouble staying on my feet. So
Yeah.
yeah,
Play and risk taking were a part of your recovery.
yeah. Healthy risk taking
Healthy, you put
in
the
inverted commas.
you mentioned you have broken bones from of the
Yeah.
risk taking, from some of the risk taking. How do you look back on that now? And is there anything you would have wanted either yourself to do different or for the people around you to do different in relation to you and the
I
risk?
would have loved the people around me to do a lot different, but the broken bone thing was I'm so clumsy. Like it's
Mhm.
hilarious. I trip over nothing. So, and I moved to Malaysia in 2014. So I lived in Malaysia and Thailand for 8 years and have only recently come back to Australia. But when the mountain bike riding in Malaysia was way too advanced and technical for me, like
Mhm.
terrifyingly so, and I wasn't able to do that. So I started running, right, which I hated prior, but anyway,
Yeah.
whatever. So I started doing that and then got into trail running. And I was doing this event and tripped over. I think I like to believe that there was a stick there or a
Mhm.
root that tripped me, but I suspect that I just tripped over my foot. But anyway, I fell face first down a hill and I broke my shoulder in a running race. But like I wouldn't change any of that. I finished the event. I didn't know I had a broken shoulder till the next day, but
Wow.
um, that sense of community and connection that comes from those activities, I
Mhm.
think, is was also a key
Yeah.
in being able to find people that had completely different backgrounds to me, but similar interests and
Yeah.
similar goals, and that sense of community and
Hmm.
freedom to be able to just go into the jungle and be with someone that I know can get me back out again.
Hmm. Yeah. So you were heard, and to you, what you gained from that, and also for you, it sounds like risk taking is part of what it means to be alive or to be fully alive.
Yeah.
So holding someone that I might get hurt and I still want to live like this.
Yeah, like I'm learning to surf now. Like I'm 56 years old in 2 days, which is super. I love my birthday. So it's
Mhm.
but I started learning to surf like 2 years ago. I am terrible at it and it's scary. Like it's really scary sometimes. And I love it. And
Mhm.
I scuba dive and that is that comes with inherent dangers, right? But if you do it, if you do these things in a measured and intentional way, then the harms can be reduced. You don't have to get hurt.
Yeah.
Like you can if you like I'm more likely to get hurt when I forget to pay attention to what I'm doing. So if I can stay
Yeah.
mindful and present, then I'm not going to trip over an invisible stick.
Yeah. And in some ways that's a parallel to the work that you do with clients where
Yeah.
this is it's risky and I know this person is in danger and I'm willing to stay with them through that for the purpose of helping them be alive or be
Yeah.
fully alive, not just coerced into living in a closed off room alone.
Yep.
And with that, we'll work together on decreasing the risk.
Yeah. And sometimes I don't like this is something that I struggle to um vocalize, I think, is being able to hold space for the potential of death. Like there's
Hmm.
some of my clients have a very, very high risk
Hmm.
and have been through so many treatment episodes and so many treatment providers that one of the first things that they find most shocking is that I'm willing to sit with them in it.
Mm-hmm.
I'm not going to call the police and get them put in hospital straight away. Like we're going to
Mm-hmm.
talk about it. We're going to work together to see if we can make a different outcome. And full consent, right? Fully informed consent. You know that this is
Mm-hmm.
risking your life. You know what the ramifications are, and
Yeah.
I can sit with you with that. It's okay.
Mm-hmm. Yeah.
We do end of life planning sometimes. Like I've got people that I've worked with on advanced care directives and
Mm-hmm.
all that kind of stuff. And um, actively suicidal clients are some of my favorite. Um, I think mainly because no one else will work with them, and generally I find them the most engaging,
Yeah.
interesting people to
Mm-hmm.
work with because I get it, like
Yeah.
I think anyone that says they've never thought of ending their life is not being honest with themselves, really. I think that everyone has that thought at different
Mm-hmm.
stages when we feel really stuck,
Yeah.
because that becomes, okay, I can't see a way out of this. I can't see a way to change this
Mm-hmm.
situation. So the only alternative that my brain comes up with is to end it all.
Yeah.
And that's how I talk about that with my clients. I'm like, I
Mm-hmm.
don't think, I honestly don't think that people actually want to die. They just can't think of a way out of
Mm-hmm.
where they
Yeah.
are.
Yeah. But when we're in pain, we want to escape. And
Yeah.
for you, it feels like death is the only way out, is the only escape. And in some ways, that's natural, or
Yeah.
it's a part of the way that our minds function.
Yep. And like if you can't, like if you're stuck in a situation that's untenable and like feels impossible, then having a clinician say to you, oh, I can't work with you unless you do this, this, and this, or unless you go to hospital, or unless you like those
Mhm.
kind of things really invalidates that level of pain that someone's in. Like they're not choosing to die most of the time. They just don't know how to make life different. And
Mhm.
societally, I don't think we do a lot to support people with that either. Like
Mhm.
access to money and healthcare and
Yeah.
all of that stuff is challenging across, I think, like I
Mhm.
know it's challenging across the states, but it's also challenging here and becoming increasingly so.
Yeah. When you're working with actively suicidal patients, something, and tell me if this feels true, but it what I'm hearing you say is I've been there, and because I've been there, I understand this in a deep way, and also maybe you're less afraid of it than somebody else who hasn't been to that dark place themselves would be. I know this
Yeah,
place.
possibly. I'm not actually afraid of it. Like I know I really strongly believe in autonomy. And if like a conversation I had with a client previously was about, okay, like if you're going to end your life, how can we do that with the minimum amount of harm?
Mm-hmm.
Right. And I'm still working with that client. So like that plan is still in place. Right. So I'm like, okay, like I'm gonna hold space for that for you, right? You're not like at right now, we're not able to let go of that. So let's make a plan that's not going to hurt you, not going to hurt anyone else, and not going to traumatize the people that find you, for example, right? So there's like that background plan with all of those things discussed really openly and really freely, and the client is making progress.
Wow.
Right. So that somehow has opened a door for them to be able to go,
Mm-hmm.
oh my God, like I can choose that, but I'm going to try this first.
You're bringing death into the room instead of shutting it out.
Yeah.
And as you do that, the person's able to look death in the face and hopefully choose life.
Yeah, and I will talk to them about, okay, let's do an experiment. Like we can keep that idea, that plan's here, right? We'll write it down. It's on a piece of paper here.
Yeah.
Let's do an experiment for 3 months and see if we can shift something, right? And
Hmm.
I'll use whatever tools I have at my disposal,
Yeah.
which is like depending on the client. And at the end of that 3 months, if generally what I find is that something small has shifted, right? So
Hmm.
then I can get another 3 months and another 3 months, and it eventually stops being necessary in my
Hmm.
experience. So I've only lost one
Yeah. Wow.
client. Yeah, maybe two. I think, not many over the in the scheme of things,
Wow.
which is
How
cool.
many, or if it feels almost like wrong to put a number, but like you've been in this for a long time.
Yeah.
Like in the um I'm like blanking on words, but in your time working from a harm reduction approach, like roughly how many people would you say you've worked with using this approach?
Nearly all of them I will go with. Like, I don't know how many, but like
So I
an
guess how many?
example.
Yeah.
So like forever, but I had a client back in probably would go like 2011, 2012 maybe, who about 2 years ago contacted me on LinkedIn. So
Hmm.
sought me out, and they're still alive, and they've got a kid, and they've got a family, and they're working and all of those things. And back, I was working with them when I was 17, and I was not sure that they were going to make it.
Wow.
And that that was the approach I used. And now they're
Mhm.
like, she had an eating disorder, she had substance use disorder, like everything, and like mini me almost. But um, hearing from her, I can't even, like, the biggest reward on the planet, I think. So how many years is that? Like 20 years later or something?
Yeah.
Someone finds me.
Mhm.
Yeah.
Wow. Yeah. And I want to also just put that you had mentioned you had lost one or two clients. I want to put that into the context of having done this for 20 years, which is, I mean, for people in this field, whatever approach you're using, um, because the phrase I hear a lot when people talk, or when people talk about just getting someone in treatment at all costs, is like better a living client than a dead one. And
Yeah.
what you're saying is that using a harm reduction approach doesn't mean I'm just letting my clients die. And
No.
I don't know like what the research or what the numbers are, but it sounds like it's pretty comparable in terms of whether somebody remains alive or not. It sounds like it's pretty comparable to forcing someone into treatment.
Yeah, I don't know the stats either.
Yeah.
I'm a qualitative researcher, so stats just make
Yeah.
my brain implode. Um,
Uh,
but I know, like, the research, some of the research, not all of it, but some of it suggests that, like, that hardcore abstinence approach is no more effective than the natural uh, change that people go through. So
mhm.
that kind of, that almost, that forced abstinence doesn't actually
Yeah.
mean any different to not giving anyone treatment at all. They'll, like, the same amount of people will eventually just stop anyway. And generally the age is around 30s when people
Mhm.
tend to drift away, like particularly in the drug use kind of
Mhm.
area. People, when they get to 30 plus, they, if they're going to stop using without treatment, then that's when that will generally happen. But
Mhm.
some of the research suggests that the 12-step abstinence model is no more effective than that.
Mhm. Yeah. And in your experience, you're working with a lot of people who've been there and maybe like you were labeled. treatment resistant, or I forget the precise words that you had gotten tacked on to you.
Man, I had so many labels. Like I could probably make a dictionary of all the different diagnoses that I was given over my time.
Yeah.
But
There there are so many gaps in your story that I want to go into more, and I also want to understand some of the pain points for clinicians or the difficult places um, in taking this approach. We'll start with the latter. So one, I feel like one of the big pieces, this is actually, are you familiar with the Hearing Voices Network?
yeah.
Total, totally different area, but I work with psychosis and have countered it feels like a parallel there as well, where there's a like just get the person into treatment. And I've seen where that was needed and actually helpful, and hearing from people with psychosis themselves who are like just stay with the experience, find the meaning in it. But so one of the questions that come up really, it sounds like all across the board, whatever the diagnosis, but with eating disorder, psychosis, and substance use, is that this notion that when a person is actively engaged in symptoms, they don't have insight into their illness, into
Yeah.
the severity of the symptoms. So I'll hear this a lot with anorexia. When somebody's malnourished, they're not able to recognize what they're doing.
Yeah.
And in order to then be able to work with the meaning behind the symptoms or um, whatever else is underneath it, we need to get them to a place that's medically stable. And once they're eating enough, they're able to see better. And I've seen this with psychosis as well. When somebody's on medication, they're more in touch with what's happening
Mhm.
work through. So how do you navigate that where um, or how have you experienced that in your own story or work with clients that we need to get to a certain threshold in order to be able to do the work is essentially
So I kind of think both need to happen at the same time. Like the
mm-hmm.
medical stabilization is essential, right? Like there's no, like I'm not minimizing that. That is it's the primary focus. But working with people outpatient, it's more about, okay, so what is the block
Mm-hmm.
between, like, you say you want to do this and then you don't, and what's happening in between
Mm-hmm.
there, and working in that space to get unblocked, I guess. So, and like, I also think that, like, yes, there is massive impairment when people are malnourished, right? Like, brains don't work properly. And I actually have not met a client that cannot see the risk of what they're doing.
Mm-hmm.
So when we focus on what's stopping you from
Mm-hmm.
doing whatever,
Yeah.
we can touch on it. Like, I can't treat trauma when someone's malnourished, but
Mm-hmm.
we can start the process so that the patient gets to have hope that it's possible. And then
Mm-hmm.
that gives them a reason to recover. So it's like finding that reason to be able to eat the food, for example, or to
Mm-hmm.
whatever
Mm-hmm.
is.
So one, you haven't worked with a client, or what I hear you saying, you haven't worked with a client who like actually literally had no insight into the risk they were in. So what you're looking at then is what's holding you back.
Yeah.
And
What purpose is the eating disorder serving? Like, what is it giving you that we
yeah.
need to find another way of meeting that need, right? So
Mm-hmm.
it's about, like, eating disorders are protective. It's trying to protect us from something. What is
Mm-hmm.
that, and how can we resolve that enough so that you can eat, while also
Yeah.
working on eating
Mm-hmm.
enough and working on the trauma at the same time in a
Yeah. Mm-hmm.
smaller, like, a not in not treatment trauma, but it's validating and recognizing that that is part of the picture and planting
Yeah.
the seed that we can get there.
Mm-hmm. Yeah. Almost creating a map of what treatment can be or and where the eating disorder falls in their internal life without
Yeah.
maybe going really deep into something that is very painful and traumatic. at that point in time.
Yeah, because kind of like what I've seen happen, I actually got more sick while I was in hospital, which is an
Mhm.
interesting phenomena that I can't quite get my head around. But um, I've seen people in treatment have the meal plans, blah, blah, blah. So weight restoration in a really rapid, short space of time and with no help to navigate those changes, right?
Mhm.
So someone with anorexia, their body is changing every day. How are
Mhm.
we coping with that? What do we need to do to support you differently with that? What is going to help this be less distressing?
Yeah.
And it may be that the weight restoration is slowed down a bit to allow for
Mhm.
more time and space to do that. And
Mhm.
that was one of the conflicts I had with the workplace I was in. They would not decrease someone's meal plan
Mhm.
to, and she ended up discharging and has
Yeah.
relapsed
Mhm.
pretty badly since then.
Wow.
So
So
yeah.
part of harm reduction then in the eating disorder space is you might be working with someone at a meal plan that's less than optimal for
Mhm.
what for their body, and knowing that as we work our way up more slowly, it'll be more sustainable for them.
Yeah, 100%.
Mhm. When you say, I'm coming back to the when you
I
say,
don't make the meal plans because I'm not a dietitian, but I
yeah,
have dietitians that I work really closely with. Like,
yeah,
I work closely with a dietitian, and we're about to start a supervision group for working with this kind of presentation and how to navigate
wow,
that.
wow,
So, and I think from what I can't find anything similar that's
wow.
specifically focused on supervision or consultation, depending on what country you're in working with these complex,
Yeah, I'd love to hear
long, generally long term.
or
I
like
can
if you,
send you the flyer. I'm meeting with Susan later to talk about the
yeah,
how is not my thing. Like I'm a big
yeah,
picture kind of person. She's got to
yeah.
do the details.
Yeah. And we can link in the show notes as well if just any
Yeah,
resources
cool.
you want to know about. When you say I haven't had a client who was not aware of the risk they were in, I'm sure you've had clients who've come to you and been like, yeah, I'm not eating enough, but like it's fine. I'm not going to die, who are like significantly medically at risk.
Yeah. I
How do
just
you?
have that conversation with them,
Mhm,
right? What makes you like, where does that confidence come from,
mhm,
given what we know about eating disorders? So pulling out some of that research and just having that conversation.
mhm,
And if weight restoration is not a topic that we can talk about right now, yeah, okay. So what areas of your life are not working,
mhm,
right? What do you want to change? And what do we need to do to change that? And often it's like more nutrition,
mhm,
right? So someone will go, I'm having trouble at school because I can't concentrate. Okay, what's going to help you concentrate more?
mhm.
Right? Better
Yeah,
nutrition. So
you're
generally it always funnels back to that.
yeah. Um, so you're working with them, looking at they might at the moment not acknowledge or recognize the medical risks that they're at, but they recognize the other areas where it's impacting their life.
Yeah. And I think at some level, they like the statement that, yeah, I know my blood tests say this, this, and this, but I'm going to be okay is mm, doesn't mean that they don't know about the risk. It means that there's a level of, I would say, fear in being able to acknowledge that.
Mhm.
And my train of thought just went,
When they're denying the medical risk, it's not that they're,
ah,
yeah.
yeah, I think that they do know
Mhm.
because in my experience anyway, they know. And if you have that conversation, you can usually get to, okay, yes,
Mhm.
I know that the risk is there, but I'm not willing to change that yet, which is where the denial of risk, I think, comes in. Like
Mhm.
if I pretend that's not happening, then it's not happening, right?
Mm-hmm.
So like I think about when we think about substance use, it's like I used a really deadly substance, right? But
Yeah.
I never thought that I was going to die,
Mm-hmm.
right? I knew other people died. I saw a lot of people die, but that was never going to happen to me
Mm-hmm.
because fuck knows why. I don't know why I'm so special, but well, it didn't. But you know,
So when you look back at your own, like you were using heroin, believing that you wouldn't die from it, you see that not as a medical result or anesthesia as people would describe it, but as a internal reaction to fear, or how would you explain that in yourself?
I needed to, I needed, I needed to use for
Mm,
whatever reason. I needed to use, and if I acknowledged that I was potentially gonna die, then that would interfere with me
mhm.
getting what I needed. So
Yeah.
I kind of equate it a little bit to that idea that um I can't remember who talked about it, but when our parents growing up are non-responsive or whatever, we blame ourselves, right? It's
Mhm.
my fault that they're not doing that because I can change it. And I see it as the kind of flip side of that. Where if I don't
Mhm.
recognize that that's possible, then that means it's not. Does
Mhm.
that make
Yeah.
sense?
Yeah. The denial is a way of coping with what feels like
Yeah,
an impossible reality in which I need to use this thing that I know can kill me.
yeah, yeah. And if I stop using this thing that I know will kill, that I know could really could kill me, the alternative, that black space of what I experienced when I wasn't using,
Mhm.
I preferred to take the risk
Yeah.
at that time.
Yeah.
Yeah,
And and as you're working with people and digging a little deeper underneath the, oh, I'm not gonna die. I'm like, yes, I know that's true of other people, but not me. What you're finding is that there is an acknowledgement of the risks that they're afraid to take. And when you make it
yeah,
safer, you're able to look at that.
yeah.
That feels true to me when I think about clients who I've worked with who are like, yeah, I'm not at risk. And then we start talking and there's they might be like, okay, I'm not at risk from dying, but I'm noticing these effects on my life and I'm scared of that.
Mhm. Yeah. And like I would never push someone to state, yes, I know that I could die from this.
Hmm.
Generally it will come from them
Yeah.
in time. They'll be
Hmm.
like, okay, now I'm scared of dying, as well as all these other things that are happening, like
Yeah.
my brain, my heart
Hmm.
rate, my whatever,
Yeah.
messing up.
Yeah. And that rings true to me also because I've seen people go back and forth between like, I'm really scared of what this can do to me. And then when there's the threat of getting placed in higher level of care, like, no, it's not actually really a problem. Like, I'm okay.
Yeah. Yeah, I'm doing great
Yeah.
because the because I think recovery for a lot of people, especially in the beginning, like recovery is more terrifying than what is happening now.
Hmm.
You know, and how do we make recovery feel less? How do we make recovery feel less scary for
Hmm.
people? And I think
Yeah.
I don't know, like some people like to just jump in cold water. I'm a toe toe first
Mhm.
kind of person.
Yeah.
Um, and I think that's how I work with my clients as well. It's like, okay, let's put a pinky finger in and test the water and
Yeah.
find out.
Hmm. Yeah. It's a really different conceptual understanding also of, and it feels like this is where people might get into that like back and forth argument of what's
Mm,
what's causing the lack of insight. Is it the medical or the malnourishment, the state of their body, or is it the psychological function of that? Which,
or is it both?
or is it both?
but that doesn't also exclude the patient or the person from being able to be included in the decision making around their life, right?
Yeah.
Like if you think about like intellectual impairment, right? Like disability services or whatever. We try and give people as much autonomy and choice as is feasible, right? Or
Hmm.
as much as we can. And someone with an eating disorder doesn't have cognitive capacity. They have
Hmm.
impaired cognitive capacity that we can rebuild, but doesn't mean that it's not there. And it's how do we access it? Because it is in there somewhere, right?
Yeah.
So yeah,
Mm.
how do we get through, how do we keep them alive long enough to be able to do some work and make some progress and get them, like I will talk to them like I'm just walking beside you on this path. Like I have a whole bunch of evidence-based practice that I draw on,
Mhm.
and I'm not going to tell you what to do. Like we're going to do this together. We're going to talk about it openly and honestly the whole time. I'm going to be open and
Mhm.
honest. No secrets, no surprises from here. And let's go for a stroll, right? Let's see where this ends up. And I think it's about building purpose and meaning is the
Mhm.
main thing. Because I think that that's something that gets taken away from us when we're in really
Mhm. For sure.
strong illness.
Yeah. What was your experience of, and after this we'll wrap up. I know we're a little over, but what was your experience with, you said you were hospitalized and got worse.
Mhm.
Um, what was your experience with either accessing insight or whatever you want to call it while in a malnourished state or getting to a state of nourishment and then accessing insight? What was that like for you?
The I had to find a reason
Hmm.
to, so like when I talked about mountain bike riding, right? Like
Yeah.
that became my reason to provide myself with enough nourishment and to take better care of myself because I wanted to be able to go mountain bike riding. Like it was the
Mhm.
thing that gave me joy and
Yeah.
pleasure or whatever.
Hmm.
And that was really where it started. And then insight developed as I began to nutritionally rehabilitate and
Hmm.
my brain
Yeah.
came a little bit back online.
Yeah. So it really was both for you. The purpose or finding purpose was the starting point. And
Yeah.
then as you became more nourished, you were able to have more insight as well.
Yeah.
But the purpose came
And then
first.
I moved internationally. Like, go figure. I'm a junkie, you know, like I'm a street junkie, and I worked in a university in Malaysia. It's just like, what, what even? How did that even happen? You know, like it still baffles me to some degree. I'm like, seriously?
Can you wrap up by telling us more about just like we went into a lot of like really deep and heavy stuff, but tell me a little bit more about your life right now and all that's rewarding and how far you've come.
Life is pretty spectacular. Like I'm looking out my window now at, I'm in a rental, which kind of sucks, but um, in my backyard, there's trees and birds and sometimes kangaroos and every now and then a snake, which is unkind. But um, I live close enough to the coast that I can go surfing. Like, so I'm 25 minutes from the beach. There's a cyclone building off the coast here at the moment, so that's not currently anything I'm doing. But
Mhm.
scuba diving, I think, was probably the thing that really saved my life. Like, prior to that, I was doing triathlons. Like I am super active and
Mhm.
have been an athlete really since I was 4, except for when I was a
Oh,
heroin addict, because both of those don't kind of go well together. Um,
yeah.
but I just got back from Orlando and like presenting at a conference in Orlando. In
Mhm.
May, I'm flying to San Antonio to present at a conference. In August, I'll be in Melbourne presenting at a conference talking about this kind of topic.
Yeah.
And the choice, the privilege, I guess, that I have now.
Mm-hmm.
Like I've got two surfboards sitting in my, just like within my vision, and I'm like, I can't even surf. Why have I got two surfboards? But like someone gave me one and then I bought one, which I don't even, some of my behavior is still inexplicable, but we just go with that. But yeah, like life is not perfect. Like I still struggle with anxiety and I still struggle with depression at times. And
Yeah.
I haven't had a panic attack for a long time, but I just had an article published, I'm gonna say December, about, I wrote a piece about a panic attack that I had last year. And
Yeah.
um like shit still happens, like
Yeah.
things still suck because I still live in the world, and I have the most incredible like life.
Yeah.
My dogs are currently in Malaysia because I can't get them home.
Mm-hmm.
So when I moved back to Australia, I had to leave my dogs behind. So I still rent a house in Malaysia where my dogs live, which sounds a little bit nuts, but that's cool. So I rent a house for my dogs, and one of my students lives in the house rent free and takes care of my babies. So I
Oh.
travel back there as often as I can to see them and go scuba diving. And
Mm-hmm. Yeah.
I just never imagined, never in
Oh.
my life could I ever imagine this was possible. And I'm
Oh.
going to do my PhD. Like, what the hell?
Mhm. So you're still experiencing the pain of being human, and alongside that, living a life that's really personally and professionally fulfilling and
Yeah.
accomplished even by external metrics.
Yeah. I have all the bits of paper and stuff, and I
Yeah.
still inside I still feel like that, like street junkie, but that's a cool kind of dichotic dichotomy to exist in.
Yeah. Well, very cool. Thanks so much for sharing, Sandy.
That's all right. It was awesome to chat with you, and I hope people get something from this that can help with their practice and working with this client population particularly.
Yeah.
So, yeah. Any questions, people can reach out. Supervision group, I'll send you the flyer so we can link that in.
Yeah.
It's going to be timed so that it'll be later in the day in the US and early morning, not early morning, but earlier in the day in Australia. So that way it's accessible for people in both
Awesome. Very cool.
locations.